Ladies and gentlemen, colleagues and friends, I would like to thank Eric and Josep to inviting me. And it has been an extremely smart agenda this morning because you heard 804.5 and FIRE 3 based on CMS. But you need to know CMS 3 is driven by RAS-mutant, and these are not included in FIRE 3 and 804.5. So to look at the treatment options in the future for mutant RAS will become very important in addition to the analysis in wild type. RAS is the most common oncogene and the most important in all cancers. Now we need to know that actually the hotspots in RAS depend on the cancer tissue specifics. So you see KRAS mutation in pancreas, colon, and lung, but you see NRAS in melanoma and HRAS in thyroid cancer and bladder cancer. And it's very important to know each of these hotspots in these oncogenes have differential transformative activity. They are different, each one to each other, which makes treatments or developing a treatment against just RAS mutation very complex. So my agenda for today is going to the mechanism of action of RAS mutations, and I have to say I learned a lot. This is not an easy talk to prepare, and it was an exciting challenge by the scientific program committee. I will show you the preclinical models, the clinical trials ongoing, and interesting data on research, on biomarkers, and my view on how to treat mutant RAS. In 2013, the NIH initiated an NIH RAS initiative to really look at the development and discovery of small molecules that bind to RAS directly, which is very difficult, and to disrupt potential signaling downstream of RAS binding to the RAS binding proteins. Different systems and different research groups around the US are involved in different assays to identify successful treatments. What has been actually not well understood is really the RAS-RAF signaling and how this can be interrupted. So a lot of structural research has been implemented within this initiative to better understand the protein-protein interaction and the complexity of these pathways. What is very important to know, the RAS protein only is active when it's in the plasma membrane. And to get there is not easy. It has actually post-translational modification, a funnelization and prenylation to be able to be in the plasma membrane and act as RAS. It then interacts with really the major interaction proteins, which are the RAF kinases, ARAF, BRAF, and CRAF. And only beyond that, you have the most common downstream effector, which is MEK and ERK. A lot of progress has been made to really interfere with the location of the RAS protein in the membrane, the interaction of the RAS protein with the RAF kinases, as well as downstream inhibitors of the signaling pathways. And I will show you some examples and some frustrations along the way to develop inhibitors. It is very important to really focus and dial into the major points of RAS protein. You see it is linked to a receptor tyrosine kinase, and then it is interacting with a gene called SOS, son of 7-less. This is a key enzyme which actually activates the protein from GDP to GTP, which is the active form of RAS. A lot of attempts have been made to inhibit these interactions. But RAS protein is characterized by a lack of drug binding domains. That's the reason you don't see RAS inhibitors left and right. It's not easy to really do it, so attempts have to be made to make inhibitors of the activation of the RAS protein to go to the plasma membrane, such as funnelase transfer inhibitors. But you also see the interaction of the RAS GTP with the RAS kinases. This is another major area of focus to interrupt this binding in addition to the downstream signaling inhibitors. Don't even try to read. That is the complexity and the redundancy of RAS signaling. That's the reason single-agent MEK inhibitors will not work, because this pathway can adapt very quickly. You see major effects. In the middle, the RAF kinases, you already know, the MAP kinase and the ERK. But you see next to it the RAL GDS, very important other targets where actually inhibitors are successful being developed. And you see on the other side the known PA3 kinase, AKT pathway, which can actually override MEK inhibitors. That's the reason when you see MEK inhibitors as a single-agent approach to RAS-mutant, it will not succeed. Now, on the far right, you see TIAM, which is a very important gene indicating the role of RAS in immunotherapies. It's a T-cell invasion and metastasis gene. So it already shows us the connection between mutant RAS, activation of these pathways, and the impact of immunotherapies. So just looking at this heterogeneous signaling, you can understand that a single inhibitor of one of these pathways will be not successful. So what are the approaches to be more successful, to maybe look upstream at the mutations of KRAS with a hotspot, particularly in G12C, D, and V, a little bit less than G13D, as well as the exon 61. Structural biology is very important, and the conformation of the protein is different in each of these mutations, requiring a different inhibitor to these specific mutations. I will show you examples that there is inhibitors of G12C, which does not work for the other hotspots. The other particular approaches is to look really at the effectors, particularly the RAF kinases, and I will give you also some examples. The farnesyl binding proteins, particularly the farnesyl transferase inhibitors, and the phosphodiesterases seem to be a very important aspect, because this is the one which interrupts the plasma membrane binding, the critical step to even be an effective RAS protein. The RAF kinases have been in the major focus of drug development. But you can see there are many family members, A, B, C, and the KSR1 and 2 pathway. Now, something very interesting is that KSR1 and 2 are actually effectors of the estrogen pathway. So there may be a link into the female gender and outcome, which has not very much been evaluated or looked at. So if you can interrupt RAS and RAF1, you will be successful, because this is an upstream event. But so far, that has been very difficult. So many people try to develop inhibitors against the RAS binding domain, much less than the cysteine-rich domain. So what are the treatment approaches so far in place? Well, there are some interesting compounds which interfere with the binding of RAS to the plasma membrane, particularly the farnesylation and prenylation. There are preclinical data saying one inhibitor is not enough, so they're now combining both an inhibitor of the prenylation and the farnesylation. For GC12C, this is a very interesting mutation because it switches between GDP and GTP. So there is a compound which actually interacts with GDP and can interrupt the signaling of this mutant RAS. Preclinical models, very successful. It doesn't work in other mutations. It seems like logical to do just a pan-RAS inhibitor, and there are some data with 2 compounds. One of them is in phase 1 clinical trials, but the data are still pending if this is successful based on the specific conformation and interaction of each hotspot mutation. There is an inhibitor, and you heard it in previously, rigosertib, which was negative. This actually interacts with this RAL-GDS and PA3 kinase pathway. But also the data have been very limited, so we do not know the success. Again, the redundancy and the adaptive features of this signaling pathway will be a major challenge. You saw SOS, that is in development, and I think maybe promising to look, because that's the binding interaction of all the mutations with the GDP and GDP conversion. There is an interesting new fact that RAS needs to dimerize. So some of the new compounds look at the inhibition of the dimerization of RAS, which has shown in preclinical models to increase sensitivity to MAC. Again, highlighting you need a dual, at least a dual approach to be successful. To give you an idea how complex these data are, that farnesyltransferase inhibitors are very successful for HRAS, but don't work for KRAS because of the differences of the protein post-translation modification. So we need to be very careful how we develop inhibitors for mutant RAS because K, H, and S are not the same. But if HRAS is present in these cancers, you see significant activity with farnesyltransferase inhibitors. So if you have the right target, you can inhibit signaling of HRAS, but remembering it does not work for all RAS mutations. So in the NIH initiative, there have been incredible progress made to establish preclinical models, and you can see them all here, to really identify new compounds in order to treat mutant RAS patients. One of these assays is actually the MEF assay, the mesenchymal embryonal fibroblast screen, and you can see these are done with Sanofi compounds and basically showed that MEK and ERK inhibitors did not do very well. Again, you now know the redundancy of this pathway will not allow very successful inhibition. But what came out was HSP90 inhibitors may be very differential to very specific RAS mutations. And when you look at the IC50 plots, you see that these two HSP90 inhibitors seem to do very well in KRAS mutation here tested in G12D, and these are now being evaluated in preclinical and early clinical trials. So there is some light at the end of the tunnel to see by specific screens that certain drugs may actually help us to treat this patient population. Now, this is a very important slide because it shows and should illustrate, even when you inhibit mutant RAS signaling, the wild-type signaling is still there and can overcome the mutant signaling to make the story even more complicated. So you need to watch out for the wild-type RAS signaling in RAS mutant when you inhibit the RAS mutant signaling. Complicated. So you need to really be very smart to develop good treatment options. Frank McCormick's group, who is the lead of the NIH RAS initiative, just published a paper in Cell. And for the first time, he divided RAS mutations in two subtypes, in the KRAS subtype and in the ribosomal S60 kinase subtype. And they are completely different and maybe need differential treatments. The RAS subtype is what we would expect, signaling in the RAS MEK-ERK pathway. But new information is that this actually is more in the upregulation of genes in the epithelial phenotype. In contrast, the RSK subtype is more mTOR and PA3 kinase, and here you have more upregulation of the mesenchymal and EMT pathway. So the first time we see now RAS mutations is not one group, but two potential groups which will help to develop specific treatments. So when we look at the Cas subtype, the VAV-MEK-ERK dependency is important for drug development. And here we are seeing potential signals with MEK inhibitors such as trametinib and salutinib alone or in combination. There are drugs which inhibit the downstream effector, which is ERK, in clinical trials. But all this data suggests you need combinations. MEK and ERK inhibitors seem to overcome the resistance seen in the early clinical trials with a single agent. There are some drugs looking at pan-VAV inhibitors, as I mentioned, the interaction with the RAS-mutant, with the effector protein, and different inhibitors inhibiting VAV and MEK. Now, there are some very exciting data on CDK4 and 6 and MEK inhibitors, and I will show you that maybe this will give us a better indication. This is in a NRAS mutant cell line, and you can see single agent palbociclib and trametinib did not do anything. But combining, you see suddenly significant tumor shrinkage or cell death. And looking at many different cell types, you see it in mutant, it seems to really work well, except in the wild type, which makes actually some sense. So smarter inhibition on dual sides in this complex signaling pathway may be helpful, and CDK4 and 6 in combination with MEK inhibitors are now in clinical trials. This is one of the examples. This is an accrued GI trial which actually looks at mutant RAS colorectal cancer randomizing to TAS-102 versus a combination with a CDK4 inhibitor and a MEK inhibitor. So this is now being developed, and we will see if there is a clinical effect as we have seen that in preclinical models. Now, you all know the particular effect of EGF receptor inhibition and that you have emergencies of KRAS mutations in the blood, and now particular trials have been developed for an emergent resistance with low allele frequency of RAS mutant to combine with a MEK inhibitor. So this is now ongoing at MD Anderson and as an NIH-funded clinical trials. So MEK inhibitors here to overcome the resistance to EGF receptor. Now at ESMO in Madrid, there was an interesting finding, very small sample size, but I need you to figure that out. Because KRAS mutant, we think this is set in stone. But we know it's not. There is a molecular dynamic under treatment pressures. And here in a small series from Dr. Gazzaniga, which was presented at ESMO and now published in a case report in the Journal of Clinical Oncology, Precision Oncology, showed 5 out of 10 patients identified as KRAS mutant treated with bevacizumab-based chemotherapy lost their KRAS. And some of these patients were treated with cetuximab with a partial response. So I think we need to figure out that when we check for KRAS mutations, we need to monitor for it, because if it disappears here in liquid biopsy, that may open a new opportunity. We need to validate these findings, but keep our minds open that it does not only go in developing resistance, but losing genes responsible for resistance in the first place. So we also know that particular the RSK subtype is dependent on metabolic dependency, particular glycolysis. You can see KRAS or BRAF mutant have a significant upregulation of GLUT1 to get glucose in the cell. They have also high levels of reactive oxidative species, so can we take advantage of it? And the answer is yes. Easily. We can use vitamin C to inhibit GLUT1 and actually attack the vulnerability of the cells depending on glucose metabolism. And we know in preclinical models it works. In clinical trials, pancreas cancer has shown partial responders with high-dose intravenous vitamin C, but only in mutant, not in wild type. So this is now in a clinical trial ongoing in the US. Our group presented for the first time that the glucose transporter and the vitamin C transporter was highly significant in the FIRE3 trial. This was not even given vitamin C. The regulation of mutant with this transporter plays already a role without intervening, and that may be further reason to evaluate the role of vitamin C in mutant RAS. In fact, this transporter as a SNP was highly associated with the gene expression in the tumors. So we know this is for real. How we take advantage, we need to be smart to develop clinical trials. This is the clinical trial with vitamin C. You know, high doses. Low doses do not do it. It's 1.25 grams per kilogram, 3 to 4 times a week. Ongoing for pancreas and colon cancer. I'm finishing up with the New England Journal paper of the T-cell transfer targeting mutant RAS. Only mutant RAS, not wild type. I told you about the TIAM gene and regulating T-cell activity. So here are the data linking RAS with the immune system. RAS signaling has an impact on TILs in the tumor. We know it regulates GM-CSF and it upregulates PD-L1 on T cells. Again, T cell regulation. We know that TILs particularly recognize G12D, not all hotspots, and that this will allow a potential adoptive T cell transfer, which was shown by Dr. Rosenberg, but here you need to have the right HLA type. G12D are now being evaluated for special vaccines in combination with GM-CSF because this opens up the opportunity for T-cell recognition. And combinations of MEK and PD-L1 have been shown today, not successful. You probably now know why. It's not enough. So what is so different with mutant KRAS? We actually did a large study on FIRE3 and TRIBE and Maverick. The biomarkers predicting outcome for mutant RAS are completely different than wild type. But when you look in this list, you can see TPK1 and you can see KSR2. These are the critical enzymes which actually pop up in lethal screens as most important factors associated with outcome in patients not treated with any inhibitors of RAS. But there are unique clues. Maybe we can develop better treatments. MLH1 activation seemed to be very important for the efficacy of chemotherapy in FOLFIRI-BEV in mutant RAS. So DNA mismatch repair may play a role. Is that important? Or immune regulation, CCL2, one of the major factors for tumor-associated macrophages. Again, only positive in mutant, indicating again a link to the tumor microenvironment here, the tumor macrophages and not the T cells. So there are unique opportunities we see in the clinic and preclinical models to develop better treatment options. So what is the current view? You would probably agree with that, and here is kind of my take. So do we do in the future cetuximab when RAS mutation disappear? Maybe. Data needs to be shown. In mutant BRAF, I think we all move with the BRAF inhibitors with cetuximab and the MEK or irinotecan in the first line. These trials are already ongoing. MSI high mismatch repair will move, PD-L1 inhibitor will move into first line. So the whole shake-up will be very important. Are we doing the right thing right now? Is the treatment we suggest really effective? Well, there are interesting data. This is from Herb Horvitz showing that the efficacy of bevacizumab, our default, seemed not to work very well in mutant. You can see in the subset analysis it did not associate with overall survival, only wild type in the registration trial. When you look at the FIRE3 data, you see higher response rate and a longer progression-free survival, but the overall survival in mutant versus wild type BEV was the same than cetuximab. When we look at other anti-VEGF, if this is BEV or RAMI or alpelisib, all have not shown significant activity in mutant RAS. So is anti-VEGF really our good default? I think we need to be really careful in the future. Does chemotherapy make a difference? Well, this data was already shown, but here I'm focusing on the green lines on mutant. Cremolini showed in mutant RAS, when you add oxaliplatin to FOLFIRI, it did not matter. And when you added on the other side to 5-FU BEV, irinotecan, it did not matter. So our chemos are not very effective in mutant RAS as well as our antibodies. We really need a new approach. And here comes my conclusion. RAS is the most common mutant oncogene and one of the most important targets we need to really be successful. New understanding of functions of RAS in the membrane, downstream signaling, and the metabolic dependency will allow us to develop new successful treatments. However, the complexity, the redundancy, and the adaptive feedback in this complex pathway remains a significant challenge. Only combinations with novel inhibitors, which we discussed, will hopefully be successful. We need to understand biomarkers for mutants are different, and they may give us some clues for new novel targets, and we just need better treatments for mutant colorectal cancer. Thank you very much.